Okay, so the last thing that I want to talk about is something called acute respiratory distress syndrome, which is also ARDS, okay? And so when you're talking about it, this is a progressive form of acute respiratory failure. So you start out with acute respiratory failure, and then you can progress actually to what we call ARDS, okay? And there's a lot of things that happen with ARDS, okay? And there's a lot of different mnemonics out there that people use, that you listen to with ARDS. But the one of them that I saw for ARDS, okay, this is sort of like a mnemonic of what's kind of happening in the body. And I know the lady that you listen to is different, but I don't care. So this is assault to the pulmonary system. And that's what's happening in the very beginning right there. So assault to the pulmonary system, okay? So that's the first thing that's going to happen, and I'll go through this pathomap in a minute. So you get an assault to the pulmonary system, and then the person's going to go into respiratory distress for lots of reasons, okay? There's a lot of things that's going to be happening in this lung because there's 3 phases to this. Then they're going to end up with decreased lung compliance, which is over on that side. Okay, decreased lung compliance. All right, and that happens like Dan talked about. We have surfactant in our alveoli, and when you lose that surfactant, right, the alveoli collapse, and then they're going to go into what we call severe respiratory failure, okay? And severe respiratory failure is equal to ARDS. All right. I liked this one better because it showed exactly the pathophysiology that was happening in the body. Okay. So again, ARDS is a progressive form of acute respiratory failure, and there's a lot. You have pictures of this map in your PowerPoint. You also have a picture of what's happening in the alveoli, which we'll talk about in a minute. When we talk about ARDS, okay? Now, this can happen very suddenly, and what happens is that, and this is kind of doing it in a nutshell, and then I'll get into some of the actual pathophys more in depth. But what's going to happen over time is that alveolar capillary membrane is going to be damaged, and when that alveolar capillary membrane becomes damaged, what's going to happen is that you're going to get fluid, okay, in the interstitial spaces right here, okay, and then you're also going to eventually get that fluid going into the alveoli, okay. So not only do I have fluid in the alveoli, but now I have fluid in these interstitial spaces. So this is going to make it even harder for me to oxygenate the patient. And this is happening because of damage to this alveolar and pulmonary capillary membranes, all right? So we're going to get fluid moving, and I'll go into that in a second, all right? And then what's going to happen over time is, remember when we talked about sepsis, we talked about how you get increased capillary permeability, right? You get vasodilation, you get microemboli, etc., because of chemical mediators in the body. Well, it's no different when you're talking about ARDS. Okay, so it's no different than when you're talking about ARDS. The difference with ARDS, though, it has a very high mortality rate even with treatment. Okay, extremely high mortality rate regardless of what you do. Because the end result is, no matter, I can give them 100% oxygen, okay, and it's not enough. That's called refractory hypoxemia, okay, refractory hypoxemia. So I can't keep that PaO2 up even with 100% O2, okay? I cannot keep that oxygen level up because I got a mess going on in my lungs, okay? So I can't keep that oxygen level up regardless of what's going on, all right, because of everything that's going on in my lungs, okay? Now there's a bunch of causes, and you know I don't test you on causes, but I just want you to think what's going on. He even talked about aspiration this morning. Why do you never lay a patient flat when they have a tube feed? Because they can aspirate into the lungs, end up with aspiration pneumonia, okay, which triggers this whole process, okay, which triggers this whole process. Pneumonia, sepsis. Sepsis is the most common cause. Other causes are O2 toxicity, like you talked about this morning, right? Because what's O2 toxicity do? Fries the lung, right? It fries the lung. It causes inflammation and then fibrosis. And those portions of the lung are no longer able to participate in gas exchange. But regardless of the cause, I don't care what causes it, what happens is it triggers this systemic inflammatory response right here. So this is how it starts. Whatever the cause, it triggers this systemic inflammatory response, okay? When we talked about sepsis, we talked about a couple of things too going on, right? One of the things that we talked about when this happens is what's released. All those chemical mediators. Remember that slide and it says release of chemical mediators, and then it went down and it says it causes vasodilation, it causes increase in capillary permeability, right? It causes the platelets to stick together. Those same chemical mediators are released when you talk about ARDS, okay? So what's happening is you get release of all these chemical mediators, and that's what's going to cause the problem, okay? The main cause, though, regardless, is sepsis. So this is actually, this slide, this is out of your book. This is what this is right here on the board. So when you talk about this overall process, what's going to happen then is you have some insult, okay, that causes the release of all these chemical mediators, okay? So when these chemical mediators are released, what happens then is they increase capillary permeability, all right? So what that means is they cause the capillaries to leak. When those capillaries leak, what happens then is fluid leaves the capillaries, and guess where it goes? It goes into the alveoli and around the interstitial fluid. You guys have a picture like this, but you have the small version in your packet that actually shows the damage that's happening to the alveoli, okay? So basically what's going to happen, the first phase it talks about is how you have that platelet aggregating factor, which is one of those chemical mediators being released, which causes what? Microemboli. Those microemboli then, right, can narrow or occlude those blood vessels. If it narrows and occludes those blood vessels, what can it lead to? Increased pressure, right, within those lungs, or pulmonary hypertension, okay? So that's what happens first, is because of all of these chemical mediators, okay? Then over time, what's going to happen is those chemical mediators actually are going to start to destroy, okay? It's going to start to destroy this alveolar capillary membrane, okay? So that histamine, so this is histamine, right? Bradykinin, whatever you want to call it, it's going to start damaging this, okay? And what happens is when those inflammatory cells come here, all right, not only do they bring the inflammatory cells, but what's also always in there? Protein, right? So that's going to cause a change in the pressure, which hence causes the fluid to go into the alveoli and around the alveolar capillary membrane. Okay, so that's what happens to the alveoli. So what's going to happen then is you're going to start getting, this is going to get worse and worse and worse as it continues. Okay, so the goal is to try to catch this early to try to stop this. Okay, but you know how that goes, right? So eventually the end result is this pulmonary edema is going to worsen. And it's going to continue to worsen unless we actually take care of whatever the problem is that's causing this in the first place, okay? So then the other thing that's going to happen is those chemical mediators, remember, they cause bronchoconstriction. Because histamine does what in anaphylaxis? Bronchoconstriction. So now I have narrowing of my airways. Now I have fluid in my alveoli, right? Now I have clots that are further decreasing, right, the blood flow and oxygenation. So I think I call this in your book, this part, springing a leak. Springing a leak because of the capillary membrane issue. So I just I know there's other things going on, but I think I called this like springing a leak. Did I not? What I called it. Yeah, there we go. So basically, this springing a leak is due to the pulmonary edema that's going on, okay? So this pulmonary edema is going to continue until we start taking care of the problem, okay? So we get damage to the damage to the alveolar capillary membrane. Now, I will tell you, if you look in the book, it tells you that the real cause is not known. Okay, they always say that. The real cause is not known, but this is the theory. Okay, they always tell you nobody ever knows the real cause, okay? But it's thought to be due to this right here. This, which releases this, okay? So does that make sense, these chemical mediators? Histamine causes constriction, right? And then you get the histamine and the bradykinin, and it's damaging this alveolar capillary wall, right? And in this fluid is also protein, so we're changing that pressure within that vascular system, and it's causing that fluid to go into the alveoli and around the alveoli. So what's that going to do for gas exchange? Okay, it's going to decrease gas exchange because now we have a bigger gap. We're widening the gap between the alveoli and the pulmonary capillary membrane. The wider that gap, the more difficult it's going to be to oxygenate this patient. Okay?
Diffusion, right?
Correct. Diffusion. Yep. So does that make sense? And all of this causes a problem with your gas exchange. Hence, what do we need? We need oxygen, and we need what labs? We need ABGs. Okay? And we need ABGs. So that's what's critical. So as this capillary permeability increases, like I said, protein and fluid start to leak out, and they go into this alveoli. All right, and the pulmonary edema is going to worsen and worsen and worsen. Okay, that's why I called that side of the patient springing a leak. Okay, so this is just the picture showing you that. So the protein, the fluids, and all those inflammatory mediators, which were your histamine and your bradykinin, are damaging the pulmonary capillary membrane. And see the gap? See the gap? It's getting bigger and bigger and bigger. And so again, what we're doing is, as it says, air can't get into the alveoli, right? Because what's the alveoli? It's all full of fluid, right? And eventually, what's going to happen to my alveoli over here? It's going to collapse. So I'm not getting oxygenated already, and I've just started this process. Okay, so I'm already not being oxygenated. So the gap between the alveoli and the pulmonary capillary membrane is getting wider. The more distance, the more difficulty oxygenating. Okay, and that's what that was showing. All right. So basically, we have a shunt, right? And what do I mean by a shunt? Yeah, it's just going past it, right? So it's there's blood, right? And it's just going by. It's shunting. It's just going by. It's going a different path. It's going the same path, but it's not getting oxygenated or not getting perfused. Okay? And so the blood passes through right here, and no ventilation occurs. Hence, we have refractory hypoxemia, right? Over time, because this gets worse and worse and worse, okay? And what that means is it's resistant to treatment. I can put them on a mechanical ventilator at 100% O2, and I can't get that PaO2 greater than 60, no matter what I do, okay? And so that's what's happening. So they have respiratory alkalosis initially, because what are they going to try to do? Compensate. What do you do when you exercise? You breathe harder. Why? 2 reasons. You need more oxygen, and you're building up lactic acid in your muscles. And so if you don't want your muscles to hurt, you better breathe like they tell you to, okay? So that's exactly what's happening here. So initially they'll have respiratory alkalosis, but what's going to happen over time is they're going to end up with acidosis, okay? So I don't know why that's in there, but okay, so pulmonary vasoconstriction. You see this part, right? I just put this in here for this part, right? Platelet aggregating factor causes microemboli to form in the lungs, okay? Emboli form where? In this part, right? Right? Okay, so look at this person. Well, I got fluid in my lungs. Now I got fluid between the alveoli. Oh, now I have clots. So oxygenate this patient. I'm not even over here where it's getting worse. Okay, I'm not even here yet. So try to oxygenate this patient. I'm going to struggle already. And I haven't even gotten to the part where their surfactant decreases and they get atelectasis. I'm not even there yet. Okay? So think about how hard it's going to be to oxygenate this patient already. Okay? Do you see that? So already you can see why they become hypoxemic, refractory to treatment. Okay? Trying to compensate for not having enough oxygen, right? The respiratory ones make sense, right? Right? Because I'm struggling to breathe. I don't have enough oxygen. And remember, the hallmark is dyspnea. But here's the key. Progressive dyspnea. It keeps getting worse, and it keeps getting worse, and it keeps getting worse. And that's what you see happen in these patients, okay? The more alveoli that are affected, then the more problems we're going to have with actual breathing, okay? Does that make sense? Okay, so we get progressive dyspnea, accessory muscles, right? Nasal flaring, all those other things that we had over there with acute respiratory failure. It's the same stuff, okay? Now I have an elevated PAP. Why is my PAP elevated? I've got pulmonary hypertension, don't I? I have pulmonary hypertension because I have clots. I have pulmonary hypertension because I have fluid. But why is my PaOP normal? What's PaOP tell me? It's telling me what's going on the left side of the heart. But why is that normal? Because it's non-cardiogenic. The cause of ARDS is not a heart problem. So this is non-cardiogenic pulmonary edema. If you listen to the pulmonary edema lecture, what's the most common cause of pulmonary edema, did I say in that lecture? Thank you. Left-sided heart failure. This is not left-sided heart failure. That's why the PaOP is normal. This isn't caused by a heart problem. It's caused by sepsis or direct trauma or something. It's not caused by a heart problem. Hence, the PaOP is going to be normal, okay? And I know that's hard to understand, but just keep that concept in your head. It's non-cardiogenic. And if I have pulmonary hypertension, it can lead to right-sided heart failure, right? But that's not the cause of the ARDS in the first place, okay? Does that make sense? Okay. All right, so the next thing that I have here is the phase is over here, okay? And this is where we call it a compromising situation. And what do I mean by a compromising situation? It's getting worse, okay? So now we have a compromising situation going on. So basically what's going to happen now in this phase of the game is that you're getting all this decreased blood flow, right? Right? We're having decreased blood flow to the lungs, to the alveoli, and all that kind of stuff. And so what's going to happen is that decreased blood flow is going to damage those surfactant cells. And those surfactant cells help prevent my lungs from collapsing or my alveoli from collapsing. So what's going to happen is it damages those cells. Remember, he said they were type 2 cells that produce the surfactant. I'm going to have less surfactant. I have less surfactant. I'm going to lose the ability of those alveoli to open up, right? Expand and contract. And I'm going to end up with atelectasis. Okay? So think about this person. So when I think about this alveoli, okay, not only do I have all this going on, now I have alveoli, look at that are collapsing. Now you see how much harder it's going to get to oxygenate this patient? So I've got a whole bunch more stuff going on, okay? So then what happens is you also get this, I don't really care that much about hyaline membrane formation, because all it is it's necrotic cells that lie adjacent to the alveoli because I don't have blood supply. So as the tissues die and the alveoli get destroyed, you get this hyaline membrane formation, and all it is necrotic cells. And the only concern with the necrotic cells is that necrosis causes scarring, okay? And it leads to or helps exacerbate the fibrosis that's going to happen in the lung, okay? So that's the only bad thing with that. So when I say this leads to decreased lung compliance, what do I mean by that? yeah, your lungs are going to get hard. Hence, I go over here to ARDS. Okay, so you get decreased lung compliance, and then what's going to happen is that all of this over here that we started in this exudative phase is getting worse, and now this is happening on top of it. Okay, so now we're already adding to the pulmonary edema, the fluid between the alveoli and the pulmonary capillary membrane. We're already adding to the problem that we're having with clots that are forming within the vascular system. So all of this now is getting worse. So we have more and more shunting occurring, okay? And all that means is I have more and more, right? I have more and more problems going on here, and I'm not getting oxygenated, right? So there's more shunting. So more and more and more alveoli, right, are being affected, so I don't have O2-CO2 exchange. Do you see how they become resistant to oxygen? I can give them all the oxygen I need to give them, but look at all this stuff that's going on in my lung, right? I got to use PEEP to try to keep the alveoli expanded. That's one of the main treatments for ARDS patients is mechanical ventilation with PEEP, okay? But look at all this stuff that's happening. So this refractory hypoxemia is just going to continue to get worse and worse and worse, okay? And then to the patient assessment, and all this is it just gets worse, okay? Now they're starting to show infiltrates. When you look at a chest x-ray on a person with ARDS, they call it a whiteout, okay? When you look at it, it's just full. Their lungs are full of infiltrates, okay, and fluids. And you'll see that on the chest x-ray. So this is getting worse. They're struggling to breathe even more. Their respiratory rate's even higher. Their accessory muscle use is worse. Now they're having confusion, maybe some hallucinations. They're very acidotic, okay? So that's kind of what's happening in that stage, okay? So they have respiratory acidosis because obviously we're not able to have any O2-CO2 exchange. The last stage, and I call it no happy ending, this is ARDS, okay? So this is no happy ending. This is where all of that inflammation in that lung, right? Everything that happened now led to scarring and fibrosis. So any part of that lung that was affected now is like this. It's hard just like this, okay? I can't oxygenate this. How do you oxygenate this? How do you oxygenate scar tissue? You can't. It's not even pliable. You know, it doesn't even expand. It doesn't even contract, right? And so basically what they call this is lung remodeling. Just like when, you know, like your heart remodels after you have a heart attack, anytime it changes the structure of an organ, they call it remodeling. So now you have lung remodeling that has occurred right here because of all of the fluids, all of the damage to the capillary membranes, the blood clots, the lack of surfactant, right? The atelectasis, everything that happened. And so basically the amount of surface for gas exchange has been so dramatically reduced, which is why they have refractory hypoxemia, okay? I don't have a whole lot of leftover lung tissue that I can perfuse. Hence, people die. It has a high mortality rate, okay, because of all the damage in the lungs, okay? So this severe hypoxemia, then they go into multi-organ dysfunction syndrome, okay? They go into MODS. And so then it's just a spiral down. And there's not a whole lot you can really do for them when they get to this phase. Now, they can survive. I'm not going to say they can't. We had a patient who did survive this. But it's very difficult to survive this when you get to this point, okay? All right, are you good so far? Okay, so then what happen is, look what they're gonna be. All right, this is just circulatory shutdown, right? So basically what's gonna happen is your PAP is gonna be even higher, your SpO2 is even gonna be lower, your blood gases are going to show respiratory acidosis, correct? Severe respiratory acidosis. And because we have no circulation, right, no perfusion, everything's going to shut down. So this is just trying to look at the patient shutting down, okay? All right, this is the picture that you have, and you can look at this, but you know, this is just showing where things are normal. They added serotonin in there probably is the other one, but this is showing histamine, and what histamine is starting to do, right, is it's starting to damage this, and now these are all the protein and inflammatory cells that it's bringing to the area. So the inflammatory cells are going to destroy the membrane, and then because it's bringing the protein, it's changing the pressures, and it's causing the fluids now to cross that membrane and go right into the alveoli. And if you notice, it just continues and continues. And as it continues, right, we have less oxygen to be able to go into the body or to help perfuse the body, okay? We good with that? Right. So there are criteria in your book when you're looking at ARDS. Remember, it is a non-cardiogenic problem, but they will do an EKG to rule out cardiac problems to make sure that's not what they're dealing with. The chest x-ray is going to show diffuse bilateral infiltrates, which very rapidly leads to a total whiteout. So it doesn't take long to get to that point, etc. I put the patient doesn't have CHF because I want you to remember that they don't have CHF. Now, early on, if they think they're in ARDS, they're going to do serial chest x-rays, and they're going to watch how this patient is progressing, okay? Now, we're going to treat them. I haven't got to treatment yet, but we're going to treat them. But they're going to try to do serial x-rays because they want to see how bad these infiltrates are, okay? So they want to do serial x-rays because the bilateral infiltrates are a hallmark sign of this disease process. Okay, and this chest whiteout is one of the hallmark signs of this whole disease process. They've referred to this, they call it a whiteout, but some books call it a snow screen effect. So you ever have your TV and it goes out and you see all that white stuff on your screen? They kind of refer to chest x-rays like that too, if that makes any more sense to you, okay? PaO2 isn't correctable, and again, PaOP, PCWP is normal because it's a non-cardiogenic problem, correct? Right? It is not a cardiac problem. Okay. Lots of things we can do. I added to this slide. You don't have all this on your slide. I always add. But these are just some things that I added. What they're trying to do, number one, is they're trying to find a cause. And they're also doing these labs to see what other parts of the body ARDS may be affecting. And again, when you look at all of these are just all related to the organs of the body, right? Is the liver working? Are the kidneys working? You know, those kinds of things. That's all it's looking at is different areas of the body and what's happening in those parts of the body. So are my kidneys being affected? Is my liver being affected? What's my heart doing, right? So that's all these labs and stuff are going to look at, okay? So they're just your basic labs. The coagulation profile, especially because I have this going on over here, okay? So I want to look at coag profile, okay? So again, this is just kind of showing a chest x-ray of a person that has ARDS, and if you start noticing it, they're getting more and more white, right? All right, and eventually all of this will all be white too. And you see how the heart's like down, like right in here. So this is all white. You see how this has that snow screen appearance? That's what they call that right there. So the chest x-ray doesn't look very good for that patient. All right, so how do we treat it? Number one is mechanical ventilation. Okay, mechanical ventilation is extremely important, okay? Now, what you need to remember is adequate cardiac output and hemoglobin levels are critical to oxygen transport. And Dan talked about that this morning, okay? Cardiac output, adequate cardiac output, and hemoglobin levels are critical to oxygen transport, right? So if those aren't where they need to be, how am I going to help get this oxygen to the tissues in the body or to the cells of the body, okay? So the goal is mechanical ventilation. or not a goal, but one of the things we're going to use is mechanical ventilation. And what we're trying to do is keep that PaCO2 within normal limits, okay? So we don't want that PaCO2 to go too high because I want to oxygenate my patient, right? So I'm going to do whatever I need to do to keep this patient oxygenated, okay? PEEP is the most important thing in mechanical ventilation. It's the single most important ventilator treatment for ARDS, is positive end expiratory pressure, right? It's that extra pressure at the end of expiration to open up that alveoli to get it closer to that pulmonary capillary membrane so we have better O2 CO2 exchange, okay? Now remember, we said they were using lower tidal volumes, okay? And we're using lower tidal volumes because they're finding in the literature that if we use lower tidal volumes, we're going to avoid barotrauma, right? Which means trauma to the lungs from too much pressure and or too much volume, because then I can end up with a pneumothorax, okay? So PEEP is the single most ventilator treatment for somebody with ARDS. But remember, PEEP isn't always good, right? Because PEEP increases, right, that interthoracic pressure in the chest and can actually decrease my cardiac output, okay? So that's what you have to worry about with PEEP, okay? But PEEP is the thing that we really want to use on these patients because it's going to try to keep that alveoli open. Okay. Oh, there you go. So it minimizes the alveoli collapse. Hopefully it recruits more alveoli so that I can get better oxygen exchange. We already talked about functional residual capacity, right? Functional residual volume, the amount of oxygen that's left in those alveoli at the end of expiration so that I have more oxygen for O2 CO2 exchange. I need more oxygen, don't I? My problem is I'm hypoxemic. So I got to do whatever I can do to increase that oxygen, okay? It improves lung compliance because what's it doing? It's expanding and contracting those alveoli, right? You use PEEP at the end of expiration, opens them up, they close a little bit like the balloon. If you blow up a balloon, did he show you PEEP up there with the lungs?
I watched it.
Okay, there's a good video, yeah, and that's a good thing. Go on YouTube and look at PEEP of the lungs. If you blow up a balloon, right, like Dan said, it's very hard when you first blow it up, but then when you blow it up, what happens to the balloon when you're done? It doesn't completely collapse. It's still open a little bit, okay? And balloons have latex in them, otherwise they have you practice, but you can't bring latex in here. So the balloon doesn't collapse like it was when you first got it. That's what PEEP is doing to the alveoli, okay? So that balloon never goes back to that normal position. Initially, it's hard to recruit those alveoli and get that pressure in, but once you blow them up, they never totally collapse. So PEEP keeps them open a little bit all the time, okay? The biggest problem is decreased cardiac output. I decrease my cardiac output, I drop my blood pressure, okay? All right, so that's just showing atelectasis, okay? So the more atelectasis we have, the less oxygen CO2 exchange that we have. All right, so other things that we do is medications, all right? Now again, as far as medications, the only reason I put antibiotics up there is if it's caused by sepsis. And that's a gold standard for sepsis is antibiotics. So they're usually done to treat sepsis. Surfactant, this is what I'm going to tell you. The literature says that you can use surfactant. They talk about how much and how to do it, which you don't need to know. But the bottom line is this. The evidence-based practice says, is this really effective in an adult patient? Okay, there's no data that says I can give you surfactant through your endotracheal tube, right? You give them some surfactant, you turn them on the left side, it goes to the left lung. You give them some, you turn them on the right side. There's no data to support that that's really effective in keeping the lungs open, okay? But it's still out there in the literature, but there's no data to actually support that, okay? Corticosteroids, right? Decrease inflammation. So if I decrease inflammation, right, when you look at this map, I'm hoping to decrease bronchoconstriction, and I'm hoping to decrease the fluid, right? Because that's the whole purpose. So that's what I'm trying to do with my corticosteroids, okay? And if I prevent these from being released, then maybe I can prevent this part of the equation. So corticosteroids are going to work on this right here, okay? And I want them to get started as soon as I can because I really don't want it going over there and getting to that point, okay? Vasodilators are mainly used because of the pulmonary hypertension, okay? It's not used necessarily for anything in the lung, but it's used more for the pulmonary hypertension. And sometimes they do have to add like dopamine to maintain the blood pressure if the blood pressure is dropping in these patients, okay? Bronchodilators make sense, right? Aminophylline, whatever they need to use, it opens up those airways. So it's going to work right here on this part of the equation, correct? Bronchodilators. Mucolytics, right? What are they going to do? Trying to get rid of all the stuff that's in there, right? Trying to get rid of all that stuff. Now remember, like I said, when you're suctioning them, once you initiate that cough reflex, stop. Don't go any farther. Let them cough because that's going to help bring those secretions up and into those larger airways so you can get rid of them, because you can't get rid of them if they're in the alveoli, right? They have to actually go in and do a bronch and go down there and get all that out. But you can stimulate coughing to try to move that stuff into the larger airways for you to get rid of it. Now, diuretics are in here, but I'm going to caution you with diuretics because this is a non-cardiogenic problem, okay? So in the literature, they tell you that you can use diuretics, but you need to be very careful. They're using diuretics more for the pulmonary edema, not for cardiac, okay? So diuretics are used to try to help with the pulmonary edema. And so you have to be very careful because you can cause problems with fluid volume, okay? Colloids are basically your albumin, okay? And sometimes they'll add colloids right here. Remember how this protein goes with your inflammatory cells and causes the fluid to go into the alveoli? If they give you colloids, they're hoping to maintain the pressure within the vascular system so this does not happen, okay? So that's the only reason they're really trying colloids. Sedatives, neuromuscular blockers, that's for when they're on the ventilator. The vasopressors, again, is if there's a problem with blood pressure, they want to do that. Prostaglandin E, what can I tell you about that? It's experimental. What they are finding that it does is it prevents the platelets from sticking together and causing this vascular narrowing and obstruction. So it's very experimental in ARDS, but it's out there, okay? So that's why I just put it up there, because it is experimental, okay? Now, I will tell you, fluid management I don't have on here in and of itself, but it's very complex in ARDS. Okay, and I'm going to give you some evidence-based practice here, and I always have to read it so I get it right. But it's very complex in ARDS because the lungs are full, right? The lungs are full. However, what's happening is, especially if it's caused by sepsis, the patient doesn't have enough volume to maintain blood pressure, right? Because the blood vessels get big, especially in sepsis, okay? So fluid management, it says evidence-based practice states that patients with ARDS who receive conservative fluid therapy, okay, conservative fluid, not lots of fluid, okay, this is what they're showing. So the key word they use is they don't know how much fluid is necessary. So they say optimal fluid management is unknown. But they say that patients who receive conservative fluid therapy have improved lung function and shorter time in ICU and on mechanical ventilation. So what they're telling you is you have to be careful with your fluids, right? Because if you give them too much fluid and you're taxing their heart, you put them in fluid overload, right? And so the patient becomes more critical. So they don't know what to tell you with IVs. They don't know how much fluid this patient needs, right? Is what they're basically telling you. But they still use IV fluids, but they have to use them very cautiously, okay? So this is the IV person. You don't want 1,000 cc's going in, okay? You don't want that to happen, all right? A girl that we had at St. Mary's that went into ARDS was 23 years old, and she went into ARDS, and they really never found out why. And they had to send her to U of M for prone positioning because we didn't have the equipment at St. Mary's. She luckily survived. However, she cannot run anymore. She was a distance runner, and the reason she survived was because she was 23 years old with no comorbidities. Yeah, but there are beds now that do the prone positioning for you, okay? So there are beds that do the positioning, okay? So again, positioning strategies, turn from supine to prone, right? So you need to be careful, but this is what I want you to take off this slide. This is what prone positioning does right here, okay? It decreases that atelectasis, it mobilizes those secretions, and it decreases that fluid in the alveoli. So that's what I want you to take from that slide, okay? So decrease atelectasis, secretions, decreases fluid in the alveoli, okay? That's what prone positioning does, all right? Okay. So this is showing them proning without a bed. So this is in my day. So they want them, you know, they have to put something underneath them, obviously. So this is just showing them proning, and so they can still be on the ventilator, they can still be on everything. What they're doing is trying to get the dependent part of the lung up near the top, okay? The other thing your book talks about is continuous lateral rotation, okay? And this, beauty of this is you can also do vibration and percussion with these special chairs, and patients can be very easily and quickly repositioned, okay? And it allows for side-to-side turning, which is really nice. So this bed turns, actually it's a bed that turns into this chair. And so basically they maintain this lateral rotation for 18 hours out of 24 hours a day, okay? And they do it to stimulate that postural drainage and to mobilize those secretions. And like I said, you can also do chest physiotherapy with these beds. And we never had that before, okay? So 18 to 24 hours on that lateral rotation, okay? Complications, basically, the one I don't have on here, which should be on here, is MODS, M-O-D-S, okay? M-O-D-S. The rest of them make sense. Always stress ulcers, okay? And patients on ventilators alone can get stress ulcers. So even without ARDS, they can get stress ulcers, okay? And nursing assessment, you know what to assess, right? I'm not going to get into that. We already talked about that. And I just tried to put in a nutshell some of the things that you needed to do as a nurse, right? Do those make sense? Because they're all stuff that you already know, right? They're not anything you haven't seen, correct? Nutrition, you understand nutrition, etc. We good with that? Okay. How do I know what I'm doing is working? That's the piece you need to take up a level in this semester. Now this is what I'm doing. How do I know it's working? How do I evaluate whether this is working or isn't working? Okay. That's where you need to go, is to this part. So I got good blood gases. My respiratory rate's good, right? Make sense?